anything like that. If you put something in their mouth, it's going to stimulate their gastric motility, and we don't want to do that. If they're a diabetic, they may need their insulin adjusted, and we don't give them their AM medications until after the test. What's important to know about this test, and it's not on the slide, is after they get back from this test, you need to give them a lot of extra fluids because they need to get rid of all the barium. Like I said, the barium is a liquid metal. If you don't get rid of that barium and it just sets in their bowel, it will solidify. And I've actually seen patients who've had to have bowel surgery because of the barium that we gave them for test. So anyone that takes a barium, they have to get rid of that barium. So what we'll do is we'll give them a mild laxative and extra fluid, but do know after this test that they need extra fluids to facilitate the evacuation of the barium. That might be important.
Is barium the same thing as like contrast dye, or is it different?
It's different.
Because I know like when I had my OCT, they told me like to do the same thing basically after I got the dye.
Right, because the contrast dye is really harmful to your kidneys, but they're putting that in your bloodstream, they're putting it in your vein, and this one they're drinking. But we've had, like, it's just a metal. When it goes through their system, it will clump into balls and be really hard to get out. And we've had them, actually once they've gone to the bathroom to get it out, plug up the toilet, because this is balls of this metal down there. So they have to get rid of it, very important. They get rid of that. Another type of study is a lower GI. This is images obtained after rectal installation of barium. It's called barium enema. They can diagnose polyps, tumors, and other lesions. It takes about 30 minutes. You want to teach them about proper prep, getting rid of everything that's in their bowel. They'll be on a laxative, then they're on a clear liquid diet. If they're actively bleeding, they may not be able to do that prep. Post-procedure, then this is the same thing. If they've taken in barium, then we have to give them extra fluid, maybe a laxative, to get rid of that barium. They have to get rid of the barium. And this test is usually done if they complain of blood in the stool or a change in a bowel pattern, like lots of diarrhea or constipation. It can also detect a bowel obstruction. They are going to use a prep called Go Lightly. It's used for bowel cleansing, and it's actually the opposite of Go Lightly. It is this jug of fluid, and you fill it up, and then they have to drink like a cup of it every 15 minutes, and then they have explosive diarrhea. So you have to have them drink it all before they can figure out what's happening to them, or they won't want to drink it. So I've had patients who are like, no, I know what that does. But like, what, if you're not cleaned out though, you can't do the test. So, but they can see polyps. And polyps are like, they can be precancerous growths. They're usually in the lower intestine, and you may have to identify a test that would visualize that. And it's probably not going to be the upper GI. We also do CAT scans. These quick, painless. They are used to diagnose appendicitis, inflammatory conditions. An MRI, they're useful in diagnosing bleeding, fistulas, tumors, cancerous tumors, and problems with the blood vessels. A PET scan is used to find hot spots, usually cancer. And if someone's going for a PET scan, they suspect that they have cancer, and they suspect that it's at different locations, and they're trying to find these hot spots on their body to see where it is. And just the regular KUB, they can look for abdominal problems. Remember, it's the kidney, ureter, and bladder x-ray. But they're looking for masses, they're looking for tumors, they're looking for obstructions. They're looking for free air in the bowel in the abdominal area. So you can have air within your bowels, but you shouldn't have air outside of your bowels. If you do, that usually means that you have a hole in your bowel or you've perforated, which is very bad. We're going to talk about that. And if they see air in there, then they're going to suspect that you have a hole in your bowel. Direct visualizations. So this is where they'll take a lighted scope and they'll go through and they can record what's going on. They can actually, there's little tools and they can use this to take samples, to burn things off, to actually correct problems with it. There's also, it's called an EGD, is when they're doing the scope. But they also have a pill cam, and the pill cam is just basically this very large pill. It has 2 cameras on it, and it takes 7 photographs per second. They have you swallow this, and then it is transmitting these pictures through out, and somehow they're able to find the problem. Sounds pretty easy, but generally they want to do the actual scope. There's also one, an ERCP. It's an endoscopic retrograde cholangiopancreatitis, something or other, and that's used to help diagnose pancreatitis. They can look in the bile tracts. They can look for stones in the common bile duct. This one, they do this at the hospital where I work, and I've seen it be able to go in there and remove stones that were totally blocking the biliary duct. But they can also induce pancreatitis with this. So anything that touches the pancreas can cause it to go into pancreatitis. You can also cause perforation and sepsis with this. Colonoscopy. This is a direct visualization of the large intestine. They should be done at age 50 and then every 10 years, unless they find a problem, and they may want to do it more frequently, maybe every 5 years or less. So with this, they are going to put in a camera through your rectum and thread it up through, looking for different things. It's used to aid and diagnose. Basically, once you hit a certain age, unless you're having problems, they'll do it to try to see if they can find early colon cancer. They look for masses and bleedings. They can remove polyps. Many cancers start with polyps. It's important to know that they put you on your left side with your knees drawn up. Patient is sedated. This is very common. A lot of people will have this done. All of you at some point will look forward to this. It's not as bad as you think. Actually, I had one yesterday. Because I hit that mark. And the doctor was saying, you got to do it. I was like, no thanks. And then they kept calling. And finally broke down, had it done. And you have to get your prep. The worst part was the prep. And I was here Tuesday, and I was like, Tuesday they said you couldn't eat anything. You know, you just drink some broth. I'm like, yeah. Well, I tell you what, people have free pizza here Tuesday. And I was like, okay, I gotta get out of here. And I'm walking down the hall, and they bring in like free nachos they were trying to look for a classroom that wanted nachos. And I'm like, man, everything's free on the day I can't have anything. And then you have to take these horrible stool softeners and a drink similar to this Go Lightly, and it's not good. I'll just tell you that. And then I go in, and I've got these big veins. They stuck me 6 times to get the IV. I was like, after 6 times, I was like, if it's not it, I'm jumping off this cart and running out of this building. And I didn't tell them that because I didn't want to make them nervous. And then I also didn't want to tell them I'm a nurse. And then here comes my wife. Well, he's a nurse. He does IVs. So I was like, oh, brother. Because then, Susan, you get scared. Because, like, you'll
And
see
they're
when,
watching you.
when you're practicing out and then the patient's a nurse or the family's a nurse, suddenly everything goes bad. But they finally got it. And then I went in there. They dope you up real good.
Those drugs are amazing.
Yeah, they
The
are.
colonoscopy drugs.
Yeah.
They're so good.
Yeah.
I came out and like I was writing something with my finger in the sky, and my wife's like, "What are you writing?" I'm like, "I don't know. There's something up there I'm writing."
I came out of mine and I was like, "Are we ready for Noble Romans?" And they were like, "What?" And I was like, "Noble Romans."
Right.
Pizza place.
Well, when we left the building, I'm like, "This is an emergency. I gotta eat something or I'm gonna die."
Yeah.
She's like, "Well, let's go home and eat." I'm like, "I need a taco. There's Taco Bell." I was like, "Give me a taco before I die. Hurry."
Yeah, because you can't eat.
Yeah. So
I was
that was a day and a half, and that was like the worst part.
I was in PO for my hysterectomy, and I woke up and I was like, dude, I'm so hungry. I'm so excited to eat. And my husband at the time was like, they're actually extending your MPO for another 24 hours.
Oh,
And I
no.
was like, are you kidding me?
Yeah, that'd be it.
So I called the nurse and I said, you need to sedate me. I said, because
Yeah.
I'm hungry and this is not going to work out. So she did.
Right. So all of you will have this at some time, and mine was all okay, thank goodness. And I'm like, I'll see you in 10 years. He's like, no, it's 5. I'm like, no. Okay. But it really matters on the prep, because if you don't prep well, they can't see anything. They'll tell you to come back another day, and you've done all that for nothing. And at the hospital, they'll send it back up with some horrible orders for you, and they'll be like soap suds enemas until clear, and all types of horrible things that you don't want to do. So make sure that they are prepped well, for everyone's sake, okay? So, but they, they'll use conscious sedation, so they're not actually putting you out totally. You're awake, you can say things. I was a little worried, like, what if I tell them something that I don't want them to know? Because I've been there with patients saying things, and I'm like, oh man, I'm gonna be that person. I'm gonna be talking the whole
Yep.
time, and who knows what I said. But then they give you Versed, and that's what this midazolam is. It's Versed, and Versed is pain medication, but also gives you amnesia, so you don't remember anything. But you're awake and able to respond to things and talk to them. And I may have been saying some things that I don't know. All right, so. So sometimes we put in tubes. We do this to decompress the stomach. So you might put an NG tube in to pull contents out or pull air out. You might need to lavage the stomach, so you're just like rinsing it out, sucking things out. So someone that OD'd, you might put a really large tube in them and try to remove what they've ingested. You can also, they use this to diagnose GI disorders, so maybe they want some GI contents, and that's how you can get them out. Also, we use these tubes to give them medicine and feeding. We treat obstructions. We can use it to compress a bleeding site, so if you had esophageal varices, and we can put this massive garden hose down your throat, then maybe it's going to press up against that and stop the bleeding. And aspirate gastric contents for analysis. That goes along with diagnosing. So you need to teach them what's going on, and you need to kind of gain their trust when you're putting this tube in, because this tube hurts. So if you're putting an NG tube down on an awake patient, if they're out unconscious, it's one thing, but if they're awake, you know, we've taught you in the lab, like, you just go ahead and you put this tube in there. Well, your nose is so sensitive. Like if you take your pencil or your pen, you start to put it in your nose, you're going to stop pretty quickly. Okay, well imagine something the same diameter and it's not stopping. And that's why a lot of times when you go to put it down, they grab your hand or they're like freaking out, moving their head back because it's very painful. And if you don't get the right area and you're going kind of rough, it starts bleeding and they freak out. So a lot of times when I'm putting the tube in, I will tell them, you know, if they're alert and can cooperate, that we can take breaks. And then they kind of feel like they're in control a little bit. And I'm like, okay, I'm gonna put this tube in, and if it gets really painful and you want me to stop, just raise your hand and I will stop. I'm not pulling it out. Do not ever pull it out because they won't let you put it back in. Then they can take breaks, and then when they feel like, okay. But if you're just sitting there like, you know, putting it down, it's not going to go well. And remember when you're doing the NG that you do chin to chest, because they're wanting to go like this because you're putting something down. And that is making it want to go into their airway, and we don't want that. So chin to chest, it opens up, and then you can get that tube down there once you have them swallow. We want to confirm placement. If you are giving anything through the tube, even a flush, at most hospitals, ball included, you have to have an x-ray. If you're just putting it in to suck out stuff, then you don't need an x-ray. And you want to secure the tube. You want to make sure that they don't pull it out. That you want to prevent aspiration, because sometimes the tube gets placed in the wrong place, or they will pull it out just enough, or it gets pushed back in and it actually gets put in the lung. I've seen tubes in lungs multiple times, and then we put their feeding in their lungs and we kill them. It's very lethal to put feeding in their lungs. So before you give anything through a tube, you always have to verify placement. And the number one is always an x-ray, but you wouldn't do that every time you do it. But pulling out, aspirating something, if you see GI contents, then you know that you're in the gastric area rather than their lungs. So they have pH paper, at least they say they do, I've never really used any. But that's supposed to help confirm that it's acid and not mucus. And then we flush the tube about every 4 to 6 hours. We try to keep their head at a 30-degree angle when they have that. You want to mark on the tube. So once they place the tube in there, you take a permanent marker and you mark it. So then when you go in, that mark should be on that tube. If that mark is way out here, then you know that they've pulled it
We
out.
use tape in lab. They
So-
use tape as well?
Yes. We use Special Connect. It's like a big Band-Aid that's
Right.
designed for it that helps hold it in place. And when you have an NG tube, the contents coming out of it, they can be brown, but they're generally green. Why would it be green? What else? It starts with a B.
Bile.
Yeah, so there's lots of bile, and we're pulling out that bile. So if you see green drainage coming out, are you gonna freak out?
No.
Because that's normal, all right? You kind of all had this, how you measure. You're gonna measure from the nose around the ear to the xiphoid process. You're all, at some point, gonna dread it when the doctor has this order on your patient and it says insert an NG, and you're like, I've not done this before. And that's okay. Just grab another nurse that has and do it with your friends. Like, it's rare that I place an NG tube by myself. I usually grab some other person to be there with you, so. When we have these tubes, we might use them for feeding, and we might use it for enteral feedings. So enteral feedings is like liquid Ensure, and it's good because it keeps the GI tract functioning. It's safe, but the number one reason why I believe they do it is cost effective, yes.
Do nurses place the NG tubes that are bridle?
So they can, but usually special procedures will do that. And then that bridle is like a connector that it goes in their nose so they can't pull it out. Or it's real hard to pull it out, but those are really good. Those are good ones. But they'll do those usually in special procedures, put the patient out and then put them in. So But Ensure is cheap, so, and it keeps the GI tract functioning the way it should. With the enzymes being secreted, the acids being secreted, it's like working like it should. And that's enteral feeding, so we use enteral feedings a lot on our patients, and we can put them in through their tubes. They can use it through temporary tubes like a nasogastric tube, or maybe they have a long-term tube, which is a G tube or gastrostomy tube, which goes in the stomach, or a jejostomy tube or a J tube, which goes into the small intestines. So if you see a G tube and a J tube, they do go to two separate areas. And how they feed them is it could be an intermittent feeding. And the intermittent, they never hold this for you, but they may just have like a couple cans and they need a can of this every 4 hours around the clock. And you'd put this in through their tube like that. They usually have continuous feedings, and the continuous feedings is on a machine, and this is usually what we use in the hospital. And some of the machines, this is an older picture. The new machines, they have a flush bag, and you fill it full of water, and the pump knows when to feed them and then when to flush them. And you just program it, and it gives them the feeding, and then it gives them the flush when they need it. There's lots of problems you can have with these. Position, when they're giving a tube feeding to prevent aspiration, they should be at least a 30-degree angle. It helps reduce aspiration. But complications from having these type of feedings is diarrhea. Especially when you first start this stuff, these patients are just having it like crazy, and there's a lot of incontinence with this. They can have even more if you give them cold formula, or if you give them a rapid bolus of the feeding. Sometimes these go right through. Nausea and vomiting, we're going to check residual. So our policy at the hospital is if they're on feeding, is every 4 hours we check residual. So we'll go to the tube and we'll try to pull fluid out, and you keep pulling out until no more fluid comes out. But what we're looking for is their body able to process that feeding? So if we have a rate like at 75, and then your residual should be very little, 5 or 10 or nothing. But if you get hundreds and hundreds of residual, that means that their body's not processing, and you want to call the doctor. They usually have orders set up. I had a patient over the weekend, I think it said residual over 200 to pause the feeding for 4 hours and then resume. And if it was the same way, then to call the doctor. But what you don't want is to not check residuals, have that feeding building up and they're not processing. Because what's happening, they're kind of like, think of it, they're like semi-unconscious or really sedated or lethargic. It's coming up, and then it's real easy then to have them vomit. And then if they're not fully awake and can't get rid of all that stuff out of there, they are going to take a breath as they're vomiting, and they're going to aspirate. And then you have stomach acid burning the lining of their lungs, which is very bad. So the reason why we check residual is because we don't want to have that build up and we give them aspiration pneumonia. They also get gas and bloating. That's from maybe too much or too little fiber in the feedings. Dumping syndrome, we'll talk about that later. I believe we talked about that. It's basically when it's the dumping syndrome with the feedings coming in too quickly, it bypasses the stomach, and then it's not being broken down in the stomach. It starts to expand in the intestines. It causes bloating, cramping, and diarrhea. It can be a mess. Aspiration pneumonia, we just talked about that. So we want to keep the bed elevated. Tube displacement. So if it's not secured, or maybe excess coughing, they're just able to cough and cough and cough, and that tube gets dislodged and moves elsewhere. Tube obstructions. So you're not maybe you're not getting flushed or certain type of medications, there are certain medicines that will clump together and just turn into concrete. We used to have a common one that we gave was Prevacid, and we take the capsule and then you open it up, there's a bunch of little BBs in there. If you didn't put it in fruit juice, it solidified, and we ruined multiple tubes. And I remember I put it in a tube and it just would not go, and then I called and the doctor wasn't happy. But then later that week there was like this, it was a new drug at the time, and we had this memo that said do not give it in the tube without fruit juice, because if it clumps together it solidifies forever. So we had to give it in apple juice, and the whole time you were giving it you had to swirl it around so these little beads would not clump together. But you can get the tubes, you can get them clogged up. It's not a good thing. Sometimes you have to replace the tubes. You can get irritation from the tubes. The tube touching mucous membranes can start to break down the membranes. If it's touching the side of the nose or the side of the mouth, it will break down the skin. They get hyperglycemia, so there's a lot of glucose in there. So a lot of feedings have glucose in them. So we're going to check their blood sugar every 4 hours if they are on a tube feeding. Also, they can get dehydration, especially if they're not getting the flushes. So sometimes those will order feedings and not flushes. So if they're not getting enough fluid, that they'll actually get dehydrated while you're giving them their tube feedings. This is, again, addresses aspiration. We want to keep their head up. We want to monitor their residuals. If they have a tube that's actually in like a G or J tube that's in their skin, we want to make sure that we're doing proper skin care around that tube. So we want to prevent breakdown. So we'll just clean it with soap and water. A lot of times we'll put like a gauze around it. This helps absorb drainage, and it also is like a padding, so it doesn't like erode the skin. So the first one we talked about is parental or enteral nutrition. So that was like the Ensure, and it's going in through their tube or through orally or their G or J tube. Now we're talking parental nutrition. Parental nutrition is given through IV route, and it's a very complex mixture. It contains proteins, carbs, fats, electrolytes. Everything is broken down to the molecular form, so it doesn't need to go through your digestive tract. It's already broken down, it's ready to go, and it gives them immediate nutrition. So the goal is to improve nutrition status and to attain positive nitrogen status, which maintains their muscle mass, prevents weight loss. These people are really sick if they require this. They will only do this if they're unable to put the other tubes in, because the cost, like a can of Ensure is like $5. A bag of parental nutrition can be anywhere from $1,000 to like $1,500. So it's really costly, and you can cause a lot of cost with these. And I remember when I was a new nurse, like the first week I was working on my unit, I was spiking. You know how you want to make sure it gets all the way up in there? Well, I just went in there and they're out the side.
Oh.
And this white fluid started dripping out. And I'm like, oh no. They were able to get another one, but I remember the next week my manager said they charged that bag to the unit. So just make sure you don't do that again. It was like $1,000 bag.
But
Oops, sorry.
there's a lot of chance of infection with those as well, right? So.
There is, yeah, we're gonna talk about that. But they're very costly.
That's ridiculous.
We use this with people a lot of times that are having maybe like a pancreatitis patient who can't have anything in their GI tract, or they've had surgery on their bowels or their stomach and they can't use that to process. So they can get malnutrition. And people who have malnutrition